We are watching continuous sleep endoscopic disc monitoring in a 22-year-old female with history of loud snoring and choking. She has got a deviated septum on the right side, as you can see here. Her body mass index is 29, so she is little overweight. And her AHI on the sleep study is 33, so she is facing obstructive sleep apnea severe. You can see the turbinate hypertrophy. Adenoids are almost non-existent. Salpingo-pyramidal fold is also grade 0 by advanced classification. We are waiting for the disc to come down to 70. As the disc is approaching 80, you can see some primary epiglottic collapse. There is no lymphoid tissue onto the tongue. And the tongue is a little large, but the collapse is mainly primary epiglottic collapse. And you can already hear the sound. You can see the sound being produced by the vocal cords. Paradoxical vocal fold motion. The glottis also getting sucked inside, and more than that, the vocal cords actually getting sucked inside. Initially, the arytenoids get sucked, but later on, the arytenoids are not getting sucked, and it's only the vocal fold which is producing the sound. Pretty loud sound. Now let's just see it from the top. Okay. So what I'll do is I'll keep her mandible pulled a little forward. What will be the effect of mandibular advancement device that we are trying to see? This is in the correct range, 70. We are keeping her mandible little anterior with help of Dr. Patel. Watch for a minute. Just see, just with uh, pulling up the mandible little anterior, she's not getting those episodes. So this proves that she can do well with a mandibular advancement device itself. I need to watch it for a little more time. Can you sedate a little more. So we now want this to go down further. We are sedating her a little more. We wanted this to go down in the range of 60. Let's see what happens. Can you keep the jaw one? Let me relax the jaw. Now, the moment we relax the jaw, you can see the complete collapse of the epiglottis, primary epiglottic collapse, starting with the same collapse. Now let me watch the vocal cords. Same thing happening again. One of the options is to perform a glossoepiglottoplexy, by which we can, you know, not let the epiglottis fall behind. The only question is that what will happen to the vocal cords. Even if you perform a glottoplexy, that part will be taken care of. I'm still waiting for the disc to go a little more down. Right? The same thing has started to happen. Okay. And the moment I take the mandible a little up, see how it opens up. This is in the 60s, late 60s. With the mandible up, she is much better. If I leave the mandible now, everything collapses. Right? Same thing starts again. Right? Same thing starts. So if we can you lift the mandible again? Yes, only this. So she should do well with the mandibular advancement device. She should also do well by strengthening the median glossoepiglottic ligament. Because see, it's little lax. If we strengthen this median glossoepiglottic ligament, glossoepiglottopexy also, because she's only 22. We understand that suppose if glossopiglottopexy does not work, then she can use the mandibular advancement device. Can you hear the sound? Let me hear the sound. as we understand, this is uh, with the normal mandible. Can you lift the mandible once more? Let's just see with the mandible lifted. Is definitely much better with the mandible lifted. So mandibular advancement device, non-surgical, surgical glossopeglottopexy. If that does not work completely to strengthen this median glossopeglottopexy, then we can